All right, welcome to Dying to Tell You, the Caring Perspective. Today we have with us one of my favorite people in the world, Ryan English. He's a PA from Dallas-ish. Ryan and I know each other from undergrad. We went to college together, and we grew up in the same church denomination. They would say not a denomination, but they're wrong.
Same tradition, right?
Same tradition. So we share a similar story, I think, in at least the way that we grew up and the way that we went to undergraduate college together. I don't know. I feel a special connection to people who know the story in the way that you and I kind of share the story. So thanks for joining us today, Ryan, and maybe tell us a little bit about yourself and how you kind of came to be a PA and working in palliative care.
Sure. Thank you. Thanks for having me. I'm excited to be here. I think important things to know about me. PA was a third career for me. So I'd done some different other things, more corporate cubicle type stuff, and went on a mission trip and helped with the medical clinic. And it was really funny because it was one of the first times after going through, all of this undergrad training and youth ministry training and stuff. And, that I felt, it was the first time I felt this distinct calling. And like, oh, I should be in healthcare. This is really what I love. So when I got back from that trip, did 3 years of leveling courses and 3 years of grad school. Just a real quick, 6 half dozen there.
Career change.
Yeah. But graduated 2016, been a PA since then. I've worked mostly at the same hospital doing hospital stuff, internal medicine, and then palliative care for 3 years, which has been really wonderful. I don't know if I knew about palliative care, really. I'm sure I'd heard about it, and my classmates tell us that we had a lecture that I have no memory of in school. I'm sure it was like talking to people, yeah, sure, okay, I got to study how, these hematologist lives work. But running into it in the hospital is what really drew me to it. So I was fortunate enough to be able to move over to the team that I worked with as a hospitalist and transition in the same facility.
Yeah.
But I don't know other important things to note about me. I'm a big Star Wars nerd, and
yes,
dad,
we share that too,
and love outdoors. And once I love pranks, so one time I filled up Cody's voicemail when he was complaining that no one ever called him anymore. So that afternoon, we maxed out his voicemail. It was pretty fun.
So lovely. I felt seen and heard. Chris just messaged me. We should say what a PA is because not everybody.
Sure. So a PA, physician assistant, is a healthcare professional. We work in medicine. Take histories, diagnose, prescribe medications, order labs and studies. We work in every medical specialty. I always tell patients if they're not sure, so, I'm going to medically investigate what's going on with you, decide what I think it is, and figure out what to do about it and start that plan.
So I know you have prescribing capabilities. How does it work between you and a doctor? Because you're a physician assistant, so you're assisting a physician. Do you work like with a physician all the time?
Yeah, great question. And that's really where our profession kind of grew out of. We're always collaborating with, supervised by, in partnership with a physician is the idea. Each state is different, so I won't give you a full breakdown of all 50 because they all decide on their own. But essentially, we work with a physician in their specialty and figure out together what kind of things make sense in that setting. How closely we work really can vary. I've seen some people who are just side by side and maybe they're a room apart from their physician and then they talk about every patient. I've had experiences where it's a little bit like that, all the way to I see my physician once a month or call him if I have a question. And otherwise I'm doing my thing. So it
varies pretty widely, but you're working with a physician in some capacity.
Right. Right. Lots
Okay.
of autonomy, not so much the independence, I guess. Yeah.
Yeah. Okay. Yeah. Good distinction. And then tell us a little bit about how you got into palliative care. Well, I know you didn't listen to your lecture, but you got into it later on.
Yeah, a few things led me there. I was working night shift as a hospitalist, which means I was the primary person taking care of these patients, or my team was. And at night, we're putting out a lot of fires. Something goes wrong at night, we're running up to that room and trying to figure it out. And I got a call about a patient from family members who were worried that their dad was acting funny. When I got up there, I realized that he wasn't acting, that he had just passed away. That
Oh.
while they were in the room, he had died, and they weren't sure. And I had never explained that to someone, and I was
Uh-huh.
really unsure about what to do. So I called my the physician I was working with that night and asked him to either talk me through it or come back me up. And he came up and we talked about it. He did most of the talking, and it was really a wonderful chance to see how uh, delivering that kind of news in a delicate but direct way that is clear is important. Gives people peace. And the more I was a hospitalist, the more I noticed that there were these patients that were very ill. They had some really serious things going on. Maybe they had like several specialists or 10 specialists,
Yeah.
and
Yeah.
lots of
Yeah.
diagnoses. And they seemed to be very lost in the process. It was really tough for them to understand why they kept coming back to the hospital, why these things that they thought they were going to do haven't happened yet, or stuck on that like sad merry-go-round or hamster wheel of never really progressing. So the more I ran into that, and then I got to see palliative work more, and the more I saw palliative work in those situations, the more I felt like we were really being fruitful in helping those patients in particular see what is actually happening to them, and not just one part of it, but the whole. I started sneaking into family meetings as often as I could and asking a lot of questions. And yeah.
Yeah. Yeah. It's such good work. I don't think I could ever do. I if I wasn't allowed to be in palliative care, I would quit. I would quit being a chaplain. I would quit healthcare. I would go 10 bar somewhere or something.
Right.
Palliative care is just so meaningful, and I think it's useful to the patients, but I get a lot of meaning out of it, so which is just really the most important. Um, so, and honestly, I can't think of a better suited field for you than palliative care. I just, yeah, I can just imagine how good you are at it. So, yeah, I'm excited that you found it.
Thank you.
Yeah.
I really love it. I don't ever say it's really fun, unless I
Yeah.
don't catch myself and accidentally say it,
Yeah.
because it's not the traditional kind of,
Not,
I did a
yeah.
procedure that's exciting, but it is really, really rewarding to be able to spend time with patients. I think that's one of the secret ingredient to palliative is that
Yeah.
it pulls from the tradition of what good medicine was, 100 years ago. It's like just actually getting to know your people and spending time with them and not being rushed.
Yeah.
If you get to dive through things.
Yeah.
Plus, I get to use a lot of analogies, so I get to nerd out on how can I explain this weird part of the body to somebody. And
that, yes, right. And that too, as I am working with patients and families, the fun of it to me is how do I explain something or engage in this particular family system in a way that's going to be useful to this particular family. So it really is, this kind of communication really is a puzzle. And for me, I see it as a puzzle. And so it's a lot of fun to kind of try to work those pieces and help people understand and make good choices. So it is fun, I think.
yeah, it really is. It's not always a fun time of life for everybody, but it's
No.
a very real time of life. I was just watching a show last night, The Ballad of Buster Scruggs on Netflix, and there's this one chapter where it's such a wonderful slice of life where these two people like fall in love during a journey, and then there's like, happy parts and sad parts and tragedy and hope, and it kind of encapsulates that whole experience. I think that's one of the things I love about palliative is you get to be helping people navigate a lot of these times that are usually overwhelmingly confusing and not fun.
Yeah, not fun. And I say a lot that I get to see people really show up and be excellent caregivers and support to each other. Even when they aren't the best of friends, or when they aren't the best, have been estranged, or families are families, and everybody's complicated, but almost always people show up and are just really great to each other, and they are their best selves at these times. And that's a gift to witness, and gives me hope for the world in general,
Absolutely. Yeah, that's what I think is really rewarding, is kind of some of the rich family dynamics, and people come together around each other when that works out.
Yeah. Well, Ryan, you got a story to share?
Yes.
Tell me a story.
I think, and Cody, I have more stories than we will have time to tell if we just kept this going all month. But I wanted to tell the story about how I recognized that it was like my first kind of palliative conversation, my first palliative encounter. It was really but when I was a hospitalist, but I was working a night shift, and the beginning of the shift, early in the evening, got a page from a nurse saying patient's complaining of abdominal pain. I looked at the chart. Patient's a little bit older lady who had a lot of things going on. Metastatic cancer, including tumors in the brain, had a stroke from that, lots of other kind of chronic diagnoses as well that kind of complicated everything. When I went to investigate all this, there wasn't anything I could point at to see what was causing her abdominal pain. Ordered an X-ray. By the time that got back, it was a few hours later. It had some concerning findings on it. I ordered a CT scan to get better imaging and investigate further. By the time that came back, we're at midnight, and it shows a bowel perforation, which means the small intestine exploded a little bit or tore in one place and was leaking out all of the things that should not be in the abdominal cavity, which for anybody, for a normal healthy person, if that happens, you're going to the ICU, you might be having surgery. Most likely you're having surgery to repair that. And it's a difficult thing to manage in a normal healthy person, not, counting all of the other things she had going on. So I went to talk to her, and it's about 12:30, 1 in the morning at this point. And she had only a few words that she had access to communicate because of her stroke.
Oh, because of the stroke, yeah.
Yeah, so that was really difficult. But it was myself and the chief surgical resident. And I noticed as we were talking, the conversation started to steer towards, what is the next step in dealing with this one issue? And I remember saying, well, I'm worried about going to surgery because with everything else you have going on, it's going to make it really difficult for you to recover from surgery. And I asked the resident too, would you think she would have a hard time recovering? She's like, yes, I would. I don't know if that would be wise, but that is the next step to treat this. And I don't know if we don't treat this, then the infection's going to get worse. So kind of having that pause, and we ended up over the next few hours calling the patient's family. I had a couple of siblings that were next of kin, so we talked with them. We actually woke the oncologist up in the middle of the night to kind of pull the oncologist into the conversation, who was very gracious and generous and did not mind at all being woken up to speak into this, but helped explain to the family that this was a turning point, and that doing surgery would likely not have any benefit and only shorten the time that she had. And so we were able to have that whole conversation with everybody and kind of step back from the immediate problem and look at, what's helping you best to this problem is not what's helping you best,
Overall.
Yeah. Navigating through that and coordinating with the different teams and pulling in the family and trying to give them time to give their concerns. And I think it was such a, what you said, rewarding. Like I really felt like I impacted the last, time of her life, the last little chapter of her life. I got to help make that a lot better. And that's when I started saying, man, what is this palliative stuff? Is that a thing? Can people do this? This is pretty cool. So,
how did that end up for her? I mean, what did they? I can guess what they did, but
yeah, she transitioned to hospice care, and because of the advanced nature of everything, she stayed in the hospital for that and but her family came to be with her, and they got a really great week together. Most of which she was awake and comfortable for. She actually, for having that particular problem with the bowel perf, she actually had a fairly easy symptom control course. So we were able to keep her comfortable and awake and interacting for as long as we could. It was a much nice kind of way to cross the finish line than it would have been.
Yeah. Those things are so complicated because you have a bowel perforation, and, of course, the thing to fix the bowel perforation is very simple, right? But, there's so much more going on. For most people in the hospital, there's more going on than just the one thing. And spending that time to kind of explain all that, it takes time, and the time is a premium in the hospital. And I think a lot of times I see, providers, they don't take the time in the first instance, and that investment, because they don't make the investment, it costs them more time in the long run. And the patients and families don't really get what they need, and don't really aren't really informed about what they're consenting to. So being able to spend, make that investment in time in the first instance really will save you time in the long run as a provider. But it is also obviously better for the patients and families.
Absolutely. Yeah, it's that investment it's so expensive in our budgeted time for that day. But like you said, just for the overall well-being of the patient, obviously, but even for us, being able to manage our relationship in an encounter. That's been one of the things I try to tell students when I have them, is that, asking that very expensive question of, tell me more about that, and then waiting and listening and letting someone not only give you the information you need, but say things in such a way that they feel or recognize that someone is actually listening to them, can save you hours later on.
Yeah, for sure. And builds great therapeutic alliance. I mean, if you sit and listen to somebody, they are on your team, and they will trust you, and you can really guide somebody to something better for them when you know who they are. So tell me, what did that experience change for you? What did you learn from all that, besides that you wanted to do palliative care?
I talked to one of my attendings about this that I worked with a lot. She's a brilliant physician, and she actually did palliative for a little while until she would have had to go back and train again. Because, as you know, palliative is kind of a newer specialty. Yeah. So when it first got going, you could be allowed to practice in that specialty without board certification because it didn't exist. All that to say, she had a experience in palliative care, and I was talking to her about this, and she kind of reframed it for me some to say, we enter medicine a lot thinking that, we're fighting death, we're fighting to save lives, we're fighting to cure these diseases, but really what we're fighting for is to give people the most good days they can have. Sometimes that does mean fighting a disease, or sometimes that does mean curing something, or sometimes that does mean beating back death for a while, but sometimes it doesn't. Sometimes giving them the most good days means not putting them through all the process and things that we do that will fix, items on a list, but not their overall, what's happening to them. Right.
Yeah.
I think that really shifted how I thought about all the things that I was doing day to day. Like how much is it, one of the questions we ask ourselves when we're ordering something like a lab or an imaging study is, how will this change my management plan? Am I ordering this just so I feel better knowing this, or am I ordering this because it's going to help me make a decision? Kind of in the same way, how is this treatment? How is this care plan? How is this going to impact this patient's overall well-being in life? And I have to know more about them and what they want, what's important to them to assess that.
Right. Yeah. It's so easy, I think, it's easy to project our own values onto somebody else. We're well practiced at that, right? Like making the assumption that everybody else is like me. And like, I have very strong opinions about what I would want for myself. I've met so many people who have very different opinions about what they want for themselves. And everybody is different, and being able to understand what it is and then helping them know what these medical things are going to get them in terms of what they value and, good days, what makes a good day for somebody and what the medical procedures are going to get them in terms of good days. It's not easy to do, to suss that out. And it's, it's not easy to do. And people can't do it on their own because people just don't know.
Yeah, I know it's funny when you go through some of the just procedural steps of treating some of these things, and someone will get asked, what are your goals for coming here? Like, well, everybody's goal is the same. Like, I want to get better,
Right.
Like if we were all being honest, my real goal with interacting with healthcare is to have the body of a 25-year-old again, Put me somewhere between 17 to 25 physiologically and keep all the rest of me intact and I'll be happy. But, parts of that we're willing to trade for other parts.
Right.
This is what's so widely variable. I always use the example, I had a patient who was getting really advanced procedure done to treat an end-stage organ failure. And he said, as long as I can go back to my ranch and ride my horse after this, I'll do it. But if I can't go back, if you think that the chances are I'm not going to go back and ride the horse, so I just want to go home right now and I don't want to do any of this.
Yeah.
And that's riding a horse isn't as much as like just sitting around having a milkshake. That's pretty active. You have to be
That's right.
Stable in a lot of ways.
Stable.
But that was his, big threshold. And not everybody has that one. And some people have a lot less. So it's fascinating to tease all that out and see where people fall.
I've had patients that have said, look, if I can't be training for my marathon, life is not worth living. I've also had a patient who told her sons, she had ALS. I had this patient that told her sons when she first got ALS, as long as I'm able to communicate in any way at all, I want to live. And so she lived for years not being able to move, not being able to breathe, but was able to communicate by blinking. That's what she wanted. And it was really hard. It's hard for staff because they see that and they immediately feel something, right? No matter who they are, they feel something about it. And it's really easy to project our own feelings onto them and feel like, oh, this is not worth it, but it's not ours to decide. But it varies so widely, and we don't know what end of the spectrum somebody's on until we sit down and listen. So, good stuff. The other thing I was thinking as you were talking about that reframing of, healing and kind of fighting off death, there's this great scene in Scrubs, which, by the way, is such a good show.
Such a good show.
But Dr. Cox is saying something along the lines of like, everything we do here is just a stopgap, right? We're just pushing off death, right? And it's coming for all of us. But everything we do is just a pause. And I think that's, it was funny in the show, but it's good. It's good to be aware of that, right? Because we could do a lot to push off death. But it's the end game is always the end of the game is always gonna be the same.
Yeah.
And how we get there is what's different about it. And, we don't have a choice about how the game's going to end, but we do have some choice, at least, about how we play. So,
exactly. I always tell people that we're fighting the slow defeat.
That's right.
Trying to see how it goes till we get there.
It can feel a little nihilistic, but if you let it can be really hopeful and give you some agency. If we stop denying that we are going to die, then we can really pay attention to how we're going to spend the time that we do have. Which is, the podcast. Normally we're interviewing people who are dying, and they that's what they teach us over and over again is that, we are all going to die, and these people just have a more predictable lifespan than what I have at the moment. And how they spend that time is really important. And so, how I spend my time probably should also be pretty important to me if I'm paying attention. So,
exactly.
Well, thank you, Ryan, for sharing. You haven't written a book or have a podcast or
no.
You want to plug anything?
If wherever you are, if you're in a state that has some kind of physician assistant advocacy going on, just say thanks to your PAs and tell your representatives to, let us do things to take care of our patients. In some states it's better than others. Some states are a little behind. So it's a fun profession. And complete your advance directives.
There you go.
Yeah. Practice having uncomfortable conversations with people. It always is worth it.
Oh, it is. It's so good. It's so much fun too. Once you start, it's fun.
It's really hard to break away from it. Great.
All right, Ryan. It's just I'm happy to see you. Sorry about your house.
Yeah, that's been a weird, not fun journey. We are a month and a half, almost 2 months out from having a pretty devastating house fire, and that's why I have these weird blankets behind me. I'm in a long-term rental, but we're okay. Family's okay. It sounds like a lot of our stuff might be able to be salvaged, or a fair amount. So I did learn that insurance is insurance, and they're going to move at their pace, whether it's medical or property or whatever. That's been the weird, not fun part of it mostly, but
seriously.
Yeah.
Seriously. Well, thank you so much for joining us on Dying to Tell You the Caring Perspective. Thanks, Ryan.
Thanks, Cody.
Thank you to Ryan for joining me on the podcast. I've known Ryan a long time, and I so appreciate his kind, genuine personality. He's one of the best people I know, and I'm confident that his patients benefit from his presence and his courage to have difficult conversations in a gentle way. Love you, Ryan. Thank you for listening to The Caring Perspective. Season 3 of Dying to Tell You is well underway. We have several excellent interviews of people living with serious illness already recorded, but we're always looking for more. So, if you or a loved one is living with a life-limiting illness, you have a story to tell. Let's tell that story together. You can go to our website, dttypodcast.com, and click the Share Your Story link to get started. Remember, you can watch all episodes of The Caring Perspective on YouTube, and please subscribe to our YouTube channel. We have more guests coming each week with thoughtful stories of hope and learning at the end of life. Thanks again for listening. This is Dying to Tell You, The Caring Perspective.